Hi, everyone. I'm Mara McDermott, and I'll be moderating today's conversation. I'm a vice president with McDermott+Consulting in Washington, D.C. Welcome to today's conversation about primary care, the value movement, and Medicare Advantage. We have a fabulous panel with us today. I'll go quickly around my Zoom screen, but I'm going to let them each introduce themselves and their practices more completely. I'm going to start with Dr. Bill Wulf, Dr. Frank Sivatory, Dr. Kevin Spencer, and Dr. Lekeisha Jarrett. Thank you all so much for being with us today. We're excited for this deeper dive into global risk and Medicare Advantage and independent primary care. I'm going to start with Dr. Frank Sivatory. Can you go ahead and introduce yourself and your practice, please?
Hi, I'm Frank Sivatory. I'm a practicing family physician here in Pittsburgh. I'm president of Preferred Senior Care Advantage, our Medicare Advantage offering, and also Preferred Primary Care Physicians. We've been in existence as a group for 26 years, and we have a fair amount of experience in value-based care involved in both Track 1 ACO and Track 1 Plus ACOs. We are a very Medicare Advantage dense population, given the fact that we have an elderly population throughout the region. And we currently have 41 primary care physicians with 30 APPs working with us.
Thank you so much. Kevin, you're up next.
Hello, everyone. Dr. Kevin Spencer. I'm a family medicine physician and the CEO of Premier Family Physicians in Austin, Texas. And we've been serving Austin since 1985. We have approximately 31 PCPs now, 55 total providers. We started in the MSSP track in 2014 and have been an ACO since then. Unlike Frank's market, we are a lower penetrated Medicare Advantage market, but we're seeing that rapidly progress. And we've got approximately 20,000 seniors in global risk between our Medicare Advantage patients and the direct contracting entity patients.
Thank you. Bill.
Thanks, Mara. I'm Bill Wulf. I'm a physician and internist. I am the CEO for Central Ohio Primary Care Physicians. We've been serving Central Ohio for 25 years. We started as 33 physicians in 11 separate locations and have grown to 480 physicians in 83 locations. We've been in shared savings and value-based care for almost 10 years. We have, at this point, 270 adult primary care physicians, both family practice and internal medicine. We have 100 hospitalists taking care of our physicians, or taking care of our patients in 4 different hospitals, 30 specialists, and 90 pediatricians. We are an agilon partner since 2016 as the original agilon physician group. And we've also moved into direct contracting, and so have over 65,000 seniors at full risk contracting.
Thank you. Lakisha?
Hello, my name is Dr. Lakisha Jarrett, and I am a family medicine physician. I work for Wilmington Health. We've been serving the coastal North Carolina area for about 50 years. At this time, we have 64 PCPs and 84 specialists and 19 locations. We are lucky to be in an area where a lot of retirees are. So we have 20,000 plus seniors that we serve. And we've been doing value-based care for seniors for 9 years.
Great, thank you so much. So we're going to kick off the conversation with you, Frank, and we want to talk a little bit about Medicare Advantage. Where I live in Washington, D.C., Medicare Advantage has been in the news a lot of conversation about sort of the right policy choices to be making about the Medicare Advantage program and its future. I'm hoping you can make this a little bit more tangible for us. What is Medicare Advantage's role in the acceleration to value-based care, and how is that playing out for agilon and its partner practices across the country?
Thanks, Mara. I appreciate the opportunity to speak to Medicare Advantage and its value to the healthcare system. We've found that Medicare Advantage has actually provided a greenhouse for the transformation of care for a variety of reasons. First of all, 54% of Medicare Advantage payments are made through advanced payment models. all of which feature and highlight value-based care. And Medicare Advantage actually leads that movement and actually provides a path for all of Medicare service. And so we've found it to be a unique and exciting opportunity to change the way we deliver care to seniors. Not only that, I think patients have readily recognized that there is value in the Medicare Advantage. They save money up to $1,600 when compared to original Medicare. And they also use inpatient services 47% less frequently than original Medicare. That's a remarkable number, and that obviously reflects in the savings that seniors have garnered in the Medicare Advantage plans. And lastly, from our standpoint, our partner with Agilon has permitted us collectively as 17 different markets to invest over $20 million in quality support. And whether it be in our care management models or our transitions of care, dollars are being invested on a daily basis to improve the care delivery for Medicare Advantage patients. And as a result of that, we're able to expand access and also have the liberty of actively recruiting primary care physicians, which has always been a challenge for many of our markets. And now that we have support from Medicare Advantage global risk payments and also our partnership with Agilon, we've been able to successfully recruit primary care physicians that we never were able to do in the past. And so the Agilon network is planning on recruiting 150 new primary care physicians over the next 18 months. And now with the advent of direct contracting, we now have all of our Medicare patients in global risk models, so it provides a singular experience.
You know, it's one of the really impressive things I think about the Agilon partner practices, the amount of revenue at risk in those global risk models. Again, you know, thinking about those who maybe are new to this conversation, we got a lot of different terms here: total cost of care, global risk, two-sided risk, upside downside risk. Help us understand what the term global risk means and how it works. Kevin, I'm going to ask you to walk us through that.
Sure, happy to do that. So in the global risk model, what that allows us to do is in the Medicare Advantage plans, we take a percent of the premium into our entity that CMS is providing the plan, and then we manage the care of the patient. So we essentially pay for all of the care. If there's money left over, that allows us to do things like, with that surplus, fund care coordination, fund clinical programs that Frank said we've spent millions and millions of dollars on. We can cover operating expenses that improve our quality. We can help primary care with incentives and payment equity within multi-specialty groups and within primary care groups. So that's the general way it works. What's really important about these global risk models, and now with direct contracting, is essentially our groups can treat all the various Medicare Advantage plans and the direct contracting entity in one model. We're not adhering to quality measures or certain measures to a certain health plan or GPRO measures. We're really managing it as one thing that's best for the patient with clinical care put first. And again, we're managing the entire cost of the care in our model. You know, what that's delivered for us is really better experience and outcome. And this is where we're really proud as physicians of what we're being able to affect. You know, the wellness visit that Medicare came up with is turned out to be a very important visit. If patients get wellness visits, their quality is higher, their cost of care is lower, their satisfaction is higher. We're now executing and having 78% of our patients get a wellness visit. We're seeing 90% of members attributed to our groups being satisfied with their care. We see 95% strongly agree that they're getting comprehensive care, and really a world-class NPS score from our patients at 83. So the experience that we've delivered through the programs that Frank has mentioned, that Bill will mention later, is really resulting in a great experience for our patients. On the outcome side, we're seeing 42% lower ER utilization, and that was pre-COVID. We were beginning to see this. 40%, 47% less inpatient use, lower readmission rates. 90% of our patients are in a 4 or 5-star plan. And in many of our markets, we're a large part of the market. So we're really effectuating that. And then 90% of our providers believe and are professionally satisfied because they know we're developing quality care programs for our patients. And so that's a great example of where we're seeing the experience and outcome as the Medicare Advantage model and the global risk model and now direct contracting have been brought to our groups individually.
Really impressive results there. So we've heard today that global risk is available through Medicare Advantage and direct contracting. And one of the key features of being in a global risk model is that it provides that upfront funding as opposed to a fee-for-service model where you're being reimbursed for every service. Bill Wulf, can you talk to us a little bit about what that upfront funding has meant for your practice and the types of capabilities you've been able to build and expand as a result?
Yeah, thanks, Mara. I think everyone's familiar with the diagram, the pyramid on the left side, that as risk level increases, care needs to change. And that being from primary care for a low risk patient to really specialty care, hospital care, and then end of life care. And what that funding allows us to do is develop programs and capabilities that allow us to deliver comprehensive care to patients and essentially bubble wrap our patients, and especially those that are high risk. So what we've done in Columbus with that money is we've opened 5 same-day centers. These are urgent cares just for our patients, where after hours and weekends, our patients are able to be seen either in person or video within their own record by their own organization and continue that longitudinal care that's so important. As I mentioned earlier, we have hospitalists and we also have SNFists. So we have hospitalists in 4 local hospitals and SNFists now in 5 preferred skilled nursing facilities so that we don't lose contact with the patient as they leave the hospital, go to a SNF unit before they get home. We have dedicated nurses, transition to care nurses that manage that discharge plan with the patient and ensure that that patient is hopefully going to a preferred skilled nursing facility or has a follow-up appointment with their primary care physician. We have a hospitalist support center where all calls after hours and during hours from the floors are going into one center. That hospitalist center, we as primary care physicians can also call and ask what the best course of treatment is for a patient that may need to be hospitalized and where they should be hospitalized. We have centralized referral. We have home visiting physicians so that if a patient post-discharge needs something, we can send a social worker, an RN, or a physician to the home, either emergently or proactively. We found that very valuable to prevent readmissions. We have multiple care coordination programs for dedicated patients that require them. And then we also have a high-risk clinic, an extensive care center, and that's for those patients that are sitting in front of you as a primary care physician, and that patient can't go home, but doesn't necessarily need the ER. And historically, they were always sent to the emergency room, be it for IV fluids, IV antibiotics, steroids, oxygen support, breathing treatments. We can now send them to our extensive care center where they would receive care by a hospitalist and a hospital nurse at our own facility and prevent an ER visit and likely either an observation or an admission. We also have an ER diversion program. So when you're one of our patients and you show up in one of those 4 hospitals in the emergency room, the first person to see you is likely a COPC nurse, not to deliver clinical care, but to comfort the patient, reassure the patient, connect that patient with their primary care physician, and hopefully, by working with the emergency room doctor, prevent an admission that's unnecessary. And quite frankly, if we can reassure the emergency room physician that that patient can be seen tomorrow, that ER physician is much more likely to send that patient home. And so those are the type of programs that we're developing across the agilon network to really provide better and safer care for our patients. This is a bit of an example of the halo effect that Medicare Advantage has provided for our Medicare fee-for-service patients. And so as we entered into direct contracting, you can see that our spend at COPC in Central Ohio was $885 per member per month, a full 20% less than the regional benchmark. And unfortunately, if it weren't for COPC in this market, representing about 25% of the independent physicians, there would only be 9% other independent physicians. And the rest of the primary care physicians, that's 65%, are hospital or system employed, and unfortunately are tied to a higher expense. I would also comment that we've expanded agilon within Ohio. So it's not just Columbus. We've expanded to Dayton, we've expanded to Akron and Canton area, and we've also expanded to Zanesville and into Dayton. And this is data that again shows that in the Zanesville and Dayton market, with that halo effect for Medicare fee-for-service is also providing a 10% savings. And you can see there are a bit more independent physicians in those markets, but still over half of the physicians in those markets are system employed. And we'd like to see more independent physicians in every market because of what we can provide for our patients.
Great, thank you. So we heard a bit about the benefits for physicians and the expansion and ability to retain their independence. The global risk models also offer a tremendous amount of benefit for Medicare beneficiaries, and we want to talk a little bit about that, starting with a conversation around access and how the global risk model has created more access and more convenient access for patients. Kevin, why don't you tell us a little bit about the story in Austin?
Yeah, so historically in Austin, Texas, we had even as popular a place as that is to live, we had a PCP shortage. And more specifically, it was even worse for the Medicare age patients. And so the groups in Austin, Texas, there's now 4 of us that are in the agilon health model, the total risk model. We have really been able to expand access both in our existing locations, but also going after areas that are heavy in Medicare by putting new offices there and hiring new physicians. So where it used to be a couple months or more for a new Medicare patient to be seen in Austin, even as we were wide open, we now can see a new Medicare member in less than 2 weeks in all of our locations in Austin. We're seeing improvement in the preventive services. I mentioned the wellness visits earlier, but also our immunization rates, our readmission rates as a result of this kind of access. Access is key, and having these offices close to where people live is really key. A big problem with the Medicare population is they won't access care until it's too late if it's too hard. It needs to be more convenient. So again, we're able to use this model to take our existing business, make it stronger, and make it really stronger for our community, and especially the neediest part of our community, our elderly patients.
Thank you. So another benefit of global risk models is the ability to reach underserved communities and to drive health equity and patient outcomes. Lakisha, I want to start with you on this section to talk a little bit about the agilon experience overall with expanding access to underserved communities, and then to share your specific experience with us too.
Thank you very much. 59 million people in the United States live in health providers shortage areas. And we just found out that 43% of the Agilon Health Partners practices are located in some of those areas. 35% of Agilon Health primary care providers practice in those areas. I personally practice in one of those areas, that being Leland, North Carolina, in Brunswick County. It's a very interesting area because there's a very large retiree population that has moved from the East Coast, New York, Connecticut, all up and down the East Coast to Leland, but it's also a very rural area. So that has definitely created a vacuum where we need more and more providers. We are constantly growing. We've been able to provide a lot of after hours care, and we're trying to reach as many of those patients as we can. So, being with Agilon and being in that area has been wonderful.
I'll go
Bill,
on and yep.
I'm sorry.
Oh, no, you're
Bill,
fine.
do you want to tell us about Columbus?
Absolutely. I'll go on and tell you a little bit about Columbus. Two of the 5 counties that we serve in central Ohio are health professional shortage areas. And even beyond that, in Columbus itself, which is not one of those areas, we've established 2 clinics in low income, high need areas with agilon, one being in a market that is surrounded by federally subsidized homes, housing. And the second is we've partnered with Ohio Dominican University, also in an area of low income and significant need, where we are also working to train physician assistants of the Ohio Dominican students in those areas. So agilon has provided us the opportunity to invest in our own community to provide better care for those in need. And Kevin, maybe you want to explain a little bit about Texas.
Sure. In Austin, we had a similar experience where within Austin, we've gone to some high need areas, but just outside of Austin, about 30 miles outside of Austin in Bastrop County, in the town of Bastrop, we were able to invite a struggling rural practice of 7 providers in 2 locations into our practice and really unlock the model and serve that community, where before this model, we did not have the resources and the ability to do that. This is an area of Texas that is heavily Medicare and Medicaid penetrated, kind of a rural area, more of an impoverished area. And they didn't have any of the infrastructure to provide telemedicine, care management, transition of care, ER diversion. And so now those patients are in that community are now getting care that's really as exemplary as any in the Austin area that we see as a result of the model. And then Frank, why don't you tell us about Pittsburgh?
Sure. As I mentioned earlier, we're a 42 physician group in the greater Pittsburgh area, but 8 of our physicians serve and practice in Uniontown, PA, which is about 50 miles south of Pittsburgh, and it resides in Fayette County. And Fayette County is a low-income community, but an extremely proud community. And 8 of our physicians practice there. Anecdotally, 4 of them grew up in Uniontown, and recently 2 of them are, in essence, sons of practicing physicians. So we have father-son practices in Uniontown, all of whom grew up in Uniontown and are and live and work there on a daily basis. And so we've had tremendous success implementing the model in Uniontown and in Fayette County, with ultimately us being able to, during the peak of the pandemic, we created, the physicians actually in Uniontown created a drive-up clinic for those patients that did not have access to computers or smartphones. And they actually had our staff run out an iPad to them in the car, and they connected with our physicians. We were able to provide care to them in the middle of the pandemic, even though they did not have access to a smartphone or a laptop computer. So our experience in Fayette County and Uniontown has been greatly enhanced by our risk models and our ability to invest in this community.
The drive-up care story, I think, is one of the most inspiring ones I heard in the pandemic, and it happened in such a dark time. I was really excited to hear about that innovation and that ability to bring care to patients. So Frank, I want to stick with you. A topic I know that you're very passionate about is the role of independent primary care. And I'm hoping you can walk our audience through why that matters. Why is independence important? And how is this global risk model supporting independent physician practices?
Yeah, Mara, thank you. I think all of us in primary care have watched the inexorable march towards employed model physicians, especially in primary care, because the ability to practice independently in primary care has become increasingly difficult. And we've already shown that independent primary care physicians generally do a better job and are more efficient in the care of their patients. And so we've been really excited about the fact that as an agilon partner, we are expanding our primary care base by 10%, which is a huge number that prior to our abilities to access risk contracting, we were never able to do. So we're currently looking at, as we mentioned earlier, recruiting 150 primary care physicians, all who are going to be independent and all who we hope drink the same Kool-Aid that we do, believing that we're transforming healthcare and doing a better job. And as we look longitudinally, we see that independent primary care physicians are becoming under increased stressors to try to deliver care, and the ability to partner with agilon to be able to create models of care that are supported financially, and also to be able to look at domains of expertise within our partners within the agilon network to improve that care is a unique advantage to us as independent physicians, and our ability to impact healthcare costs and deliver care in underserved areas, I believe, is unparalleled given the partnership that we have. And lastly, I think we've noticed that independent physicians, primary care physicians, have been under a tremendous amount of stress, and whether it be financially or professionally, and with the pandemic has certainly cast a light on the critical nature of primary care physicians as they integrate into the healthcare platform. And we found over the last couple of years that we're seeing physicians burn out pretty quickly, especially in the primary care setting, because of all the pressures and the uncertainty that they're currently subjected to. And the nice thing about being partnered with agilon is that we have support both financially and professionally, but also our physicians feel like they're doing something and they're empowered and actually have an opportunity to transform care within the healthcare system that we, prior to this partnership, really didn't feel we had that opportunity. So it's been an experience for our primary care physicians that has really energized them and has made us collectively excited about our abilities to create programs that cascade on each other, that ultimately affect the care of our patients that actually occurs outside the four walls of our exam room. The reality is that as physicians, we may see patients 3 or 4 times a year for 20 minutes or a half hour, but the rest of their lives are conducted outside of our exam room. And the beauty of this model and our ability is that we now can reach out to them with programs that are outside the four walls of our exam room, and we ultimately believe will improve and impact the care that they're being delivered and also their outcomes. So from that perspective, it's been an exhilarating experience, and I think it's energized primary care physicians, especially independent primary care physicians, and given us hopefully the opportunity to really make a difference in transformation of care in this country.
Thank you so much for that. Bill, it looks like you maybe wanted to chime in there. Can I call on you?
Yeah, no, I'm just sitting here agreeing 100%. I think Frank said it very, very well. We are transforming primary care and transforming the delivery system that primary care physicians have access to.
Yeah, as I've listened to all of you talk today, it sounds like the type of healthcare system and delivery model that you would want for any of your relatives, your parents, your grandparents. And we're just so excited to be able to share your stories. I want to thank our panelists for a great conversation today, and would encourage anybody in the audience with questions to not hesitate to reach out to us for additional information or a one-on-one conversation about anything you've heard today. And with that, thank you, panelists. Thanks for joining today's discussion. You can learn more about agilon Health and its partner practices on their website.